Welcome to our Biopsychology CIA on Dyslexia, a case comparison between 2011 and 2020. Group members include Priya Chatterjee, Sanya, Ahuja, and Shambhavi, Priya. So, what is dyslexia? Dyslexia is a specific learning difficulty in reading and writing that is accompanied by an effect on the academic performance in daily tasks. It is a neurological condition that poses problems in decoding letters, words, and sentences. What is the nature of dyslexia, one might ask? It poses significant problems in reading, making it slower. The academic performance is hampered as there is a challenge in meeting the developmental standards and the main symptoms, that is, problems in reading and spelling and writing. So, what are the symptoms of dyslexia, one might ask? The main category of symptoms include number 1, reading difficulties, number 2, problem in spellings and writing, number 3, there can be a common co-occurrence as difficulty of solving maths and reasoning with dyslexia, number 4, the general academic performance is impacted as it is lower from the expected developmental age. Number 5 is the exclusion criteria, as in individuals with dyslexia should not be explained by intellectual disabilities or any sort of neurological issues. What are the types of dyslexia? So, dyslexia can be of different types, which includes developed dyslexia, that is difficulty in reading, acquired dyslexia that can be of two major types, surface and deep. Surface dyslexia is an issue in recognizing irregular words, while deep dyslexia refers to a loss in the reading ability as a result of trauma. Sensory system dyslexia can be caused due to problems in the sensory system such as auditory and visual processing. Directional dyslexia can be confusion between the right and left of the letters that look similar, such as B and D. Dyslexia with dyscalculia is a reading problem with mathematic difficulties. And attention-related dyslexia may be the problems related to letter and word identification due to problems in attention. So, what is the etiology or the causes of dyslexia? There are three main causes that include genetic factors, brain development, and environmental factors. Genetic factors basically deals with what runs in the family. Brain development might be including structural and functional differences or impairments in the parts of brain. Environmental factor refers to the exposure of the environment to language and reading development. So, let's dive into both the cases. Case 1 of Janko basically deals with a 10-year-old boy from Hungary who had his mother who have experienced similar challenges in reading. His medical history says that his pregnancy was unplanned and was accompanied with a lot of anxiety. When he was born, he was seen to have a low heart rate. Developmental history had shown that he had struggled, but his motor development was fine. Course of disorder shows that he has reading and writing difficulties with problems in peer bonding. His behavioral issues and low self-esteem peaked. At age of 9, he was labeled at risk. The biopsychological mechanisms reveal that the dyslexia was influenced by the genetic factors. There was also strong gross motor skills that were lacking, and fine motor and cognitive abilities were also underdeveloped. The clinical presentation represented that the person, Janko, had problems in reading and writing, had behavioral problems and low self-esteem, disruptive behavior in class. He was socially withdrawal and had problems with relation. He had problems with decoding words. He had quite a lot of frustration and academic challenges, although his strengths lied in sports and arts, which were overshadowed. The diagnostic tools to assess the letter recognition and verbal memory included the Ildiko-Mexner's test to evaluate reading and writing, meeting Street School's screening test for assessing reading proficiency, and Jairam-Simti cognitive profile test that examined the cognitive ability. The treatment and effectiveness showed that there was limited school support and there was minimal progress in his case. The limitation of the treatment was due to the mother's stigma regarding dyslexia and shifts in the responsibility for addressing the disability. Research findings show that in Hungary, often undiagnosed and poorly treated dyslexia can cause a difficulty to deal with problems, and there was need for more effective educational framework. The second case of CD dealt with a 77-year-old man who developed word-centered neglect dyslexia as a result of stroke. Medical history showed that he had a lot of problems of hypertension, heart failure, and pulmonary issues. 2 years prior, he had experienced a stroke in the right hemisphere and a recent stroke in the left side, weakness and facial droop, and also lead to dyslexia-like symptoms. Biological mechanisms of CD included specific letter omissions, substitutions. There was also object-based spatial representations that showed deficits in visuospatial attention. The specific cognitive domain that were affected include language processing that causes problem in phonological awareness and visual attention. Spatial attention, executive functioning, and visual processing were also impacted. The clinical presentation of this disorder by CD showed that he was able to identify letters but made errors in word reading. His left side was severely neglected and impacted. There was also a lot of frustration and irritability accompanied. Deficits include impairment in phonological processing, significant allocentric neglect, and grossly impaired reading problems. Diagnostic tools included Oxford Cognitive Screen, line bisection and cancelling task, as well as reading tests with touchscreen tablets. Treatment and effectiveness for CD also showed below average cognitive performance. He was diagnosed with ipsilateral right word-centered neglect dyslexia and left allocentric neglect. Limitation to the treatment lied in the short hospital stay and fatigue, which also causes significant restricted in the assessment. There was also lack of information regarding CD's baseline cerebral functioning, which was also raising concern for his cognitive deficits. Now, when we are discussing the similarities of the case, we can see both NJ and CD had been diagnosed with problems in reading and impairment in the same field. There was both delayed or insufficient intervention for both the cases. Recovery was slow and outcome remained unpredictable. Both had faced ongoing challenges and both seemed to have some sort of behavioral issues as well. However, there lie differences in the case. The cause of dyslexia by CD was due to a stroke in the right middle cerebral artery stroke, while J was more on the genetic side. The key symptoms for CD included substitution and omission of words, as well as reading problems, whereas in case of Janko, showed confusion in similar letters, slow reading, and attention deficits. Diagnosis and context for CD was diagnosed at 13 days post-stroke, whereas for J, diagnosis was in late elementary school. Response for treatment showed no significant improvement in the case of CD, while limited progress in case of Janko. Furthermore, medical management such as cognitive rehabilitation was done for CD, while in case of Janko, more of educational interventions were taken. Cultural context emphasized that CD's case needed more medical perspective, whereas Janko's case needed more of prejudice and against dyslexia, which caused stigma and delayed help. In case of impact on quality of life, we could see both were impacted. CD's daily reading activities was affected vastly post-stroke, and Janko's academic success and social life as well as emotional well-being were also compromised. Overall influence showed that in case of CD, which was more focused on reading abilities with lesser problems in emotional sphere, whereas in Janko's case, dyslexia had broader impacts on personality as well as personal relationships. Now, when we are talking about advancement in the fields, we can see that at present the biopsychosocial model is taken into consideration, where emotional and social environmental aspects are also taken into consideration. The comorbidity of dyslexia along with other neurodevelopmental problems such as ADHD or using a multi-deficit model to integrate a multisensory integration approach to diagnosis and treatment are also being used. Additionally, we can also see the MTSS, that is the multi-tier system of support that aligns the biopsychosocial model has also been used for accurate diagnosis and proper individualized interventions. Sensory processing problems related to dyslexia are also focused on research as there is an interaction between cognitive deficits and sensory processing. Now, implications for clinical practice may include early diagnosing and screening of dyslexia. That might include academic failure as well as psychiatric syndromes such as anxiety and depression. Research and clinical practices also show that inconsistency and prevent effective provision of support. A concurrent and consecutive explicit and implicit learning strategies were required to strengthen letter speech sound association in effective dyslexia intervention, as well as in enhancing the reading proficiency due to the treatment of whole language processing deficits. The conclusion of this case study would be that there is a more biopsychosocial lens to dyslexia that is required for early personalized intervention. Dyslexia is not just a biocognitive lens, but a psychosocial point as well. Lastly, there is a lot of tailored approaches required for comprehensive support system for dyslexia. This holistic understanding needs to be implemented for effective strategies and interventions to address both cognitive and socio-emotional aspects of dyslexia.